Hello everyone. So today we'll be starting with the topic peptic ulcer disease. Most of you would have studied this in your first year. We'll be studying it in a more systemized and an organized manner now. Alright? So let's start with the definition of your peptic ulcer disease. So it is if the lining epithelium, right, is destroyed by excessive HCl, which leads to peptic digestion of the epithelium. It is known as your peptic ulcer disease. Alright? So that was the definition. Now let's come to the etiology. Alright, what are the causes that lead to your peptic ulcer disease? So your PUD usually results from severe stress. Yeah, so as you know, stress can be of two types. It could be your psychological stress, yeah, or your physiological stress. Alright, so your psychological stress could include your normal stress or anxiety, whereas your physiological stress includes shock, severe trauma, excessive burns, yeah, also your intracranial lesions, certain drugs such as your NSAIDs, steroids, and cocaine, alright, and certain local irritants like your alcohol and smoking. Alright, now the most common etiological factor is your H. pylori. Alright, there's also your Zollinger-Ellison syndrome, yeah, COPD, certain genetic factors which is seen in your O blood group. Alright, basically individuals with O blood group are more common or have a higher risk of peptic ulcer disease. Alright, so now that we're done with the etiology, let's come to the pathogenesis. Yeah, so in the pathogenesis, basically these etiological factors, what do? They stimulate excessive HCl production. Yeah, all these etiological factors that we read above, they stimulate excessive HCl production, which leads to epithelium damage, yes, leading to your peptic ulcer disease. Alright, so now we're done with your definition, etiology, pathogenesis. Alright, let's come to the location. Alright, how your peptic ulcer is distributed. Right, this is your cardia. Around here is your pylorus. Alright, your duodenum comes here. Alright, and this is your Meckel's diverticulum. Alright, so your ulcer could be located here. Alright, and this would be your duodenal ulcer. Alright, or it could be located anywhere in these regions. So this would be your gastric ulcer. Alright, now the ulcer could also be located here. This would be your marginal ulcer. Yeah, and it could also be located here. That is your peptic ulcer disease in Meckham's diverticulum. Alright, so these are the distributions of your gastric ulcer, of your duodenal ulcer, of your marginal ulcer, and your peptic ulcer disease in your Meckel's diverticulum. Alright, so now that we're done with the distribution, alright, now let's come to the morphology of your peptic ulcer disease. Alright, so let's start with your gross features. Yeah, so first, the ulcer is usually your punched out ulcer. Yes, it is round to oval. Yeah, now it can be of two types here. So the first, the surrounding mucosa, yes, gels with the ulcer. Alright, this is usually seen in your small size punched out ulcers, referring to the benign ulcers. Alright, whereas if the surrounding mucosa heaps up, alright, so basically something like this. Alright, so this is the ulcer and this is the surrounding mucosa. As you can see, the surrounding mucosa is heaping up. Yeah, so if this happens, the ulcer is usually malignant, and the reason for the surrounding mucosa to heap up is due to your proliferation. Alright, so now let's come to the base of the ulcer. The base is usually clean. Alright, coming to its depth. The depth is superficial, alright, but can perforate. Alright, now let's come to the complications of your peptic ulcer disease. First is your bleeding. Alright, so when does bleeding occur? If there's erosion of a major blood vessel. Alright, second is your perforation. Third is chronic stricture induced obstruction. Alright, fourth is your dysplasia. Now this dysplasia usually occurs due to H. pylori infection. Alright, yeah, so now we're done with the complications. Now let's study your peptic ulcer disease based on its two most important locations. Alright, which are it could either be your gastric ulcer or your duodenal ulcer. Alright, duodenal ulcer being more common. Alright, so we'll be starting your gastric and duodenal ulcer in a table form. Alright, so we'll start with the features. The first feature we'll be starting with is your incidence. Alright, so a gastric ulcer is comparatively less common than a duodenal ulcer. Alright, I'm gonna write D/E for duodenal ulcer, and this is more common. Alright, 4 times more common. Yeah, now your gastric ulcer usually occurs beyond 60 years, whereas for your duodenal ulcer the age is 25 to 60, and even in that range. Alright, both are more common in male. Alright, So now we're done with the incidences. Let's come to the etiology. Yeah, so why does gastric ulcer occur? This occurs due to disruption of your mucous barrier. Alright, so the disruption of the mucous barrier could be due to any of these reasons, such as your gastritis, your bile reflex, certain drugs, alright, alcohol, tobacco, and your H. pylori. Alright, so now coming to the etiology for your duodenal ulcer. Alright, this is usually due to your increase in your acid pepsin secretion. Yeah, so the reasons for these could be your H. pylori infection. 2 is your alcoholic cirrhosis. Yeah, an individual carrying O blood group. Alright, tobacco consumption, chronic pancreatitis, and lastly hyperparathyroidism. Alright, now we're done with the etiology. Let's jump to the pathogenesis. Alright, so in your gastric ulcer there is increase in your serum gastrin, alright, which stimulates your increase in HCl secretion. Alright, now this HCl creates a hyper acidic environment, alright, which damages your mucous barrier, alright, eventually leading to your gastric ulcer. Whereas the pathogens for your duodenal ulcer, these factors, your increase in acid pepsin secretion, alright, makes the hyperacidic environment, alright, which leads to your mucosal digestion, alright, which leads to damage of the protective mucous barrier. Alright, so now we're done with the pathogenesis. Let's come to the pathological changes. Yeah, what are the pathological changes seen and where do we see them? In case of gastric ulcer, the most common locations which undergo pathological changes are your lesser curvature and your pyloric antrum. Yeah, whereas for your duodenal ulcer, the most common is your first part of duodenum, as the name suggests. Yes, and it's often solitary, yeah, round to oval, punched out ulcers. Yeah, good. So now let's come to the complications. Right. So complications for your gastric ulcer can be perforation, hemorrhage, alright, obstruction, and 1% chance of malignancy. Alright, whereas for your duodenal ulcer, it is perforation, hemorrhage, obstruction, but no chance of malignancy. Alright, yeah. Now we're coming to the last feature. These are your clinical features. Alright, so we'll start with your gastric ulcer. The patient presents with a food pain pattern. Okay, basically whenever an individual consumes food, alright, he develops severe pain. So any person eating food, he gets pain. So what's the first thing he will do? He will stop eating food. all right, because whenever he eats food, he ends up getting pain. So this is what we see a food pain pattern, all right. So the pain is very bad, so what is the first thing he'll do? He'll stop eating food. So what happens then? There is loss of weight, all right. And when does this person, usually a person doesn't eat food at night? Why? Because they're sleeping. So in this condition there is no night pain, all right. Also, this person has vomiting. Why? If the person eats food, he or she might vomit, all right. And there is deep tenderness in midline in your epigastrium, all right. Those are the clinical features for your gastric ulcer, all right. So basically this individual is going to look skinny, all right. So now let's come to your duodenal ulcer, all right. So this person has a pain food relief pattern, all right. So what do you get from this? This person eats food, his pain starts coming down, all right. So how will this person present as? He'll have increase in weight, all right. So whenever he's not eating food, he will have pain, but when he's eating food, he will not have pain, all right. So this individual will have night pain, all right, because that's when he will not be eating food, all right. And this person has no problem when he eats food. In fact, his pain reduces. So this individual again will have no vomiting, all right. And yeah, increase in weight, most important. So because this is how, when the patient comes to you, so you can see like, okay, this person has increase in weight, he's complaining with these symptoms and features, so you'll know, okay, this person is duodenal ulcer, all right. And here lastly there is deep tenderness in your right hypochondry, all right. So these two things you need to keep in mind, because this is how your clinical questions will be asked, all right. So all right, so here we see your ulcerated mucosa, all right. Then we come to your necrotic zone, all right. So what is this necrotic zone? This necrotic zone is composed of the following things. First being your fibrinous exudate, all right, leukocytes, and your necrotic debris. Yeah, and where is this necrotic zone located? It is located in the floor of the ulcer, all right. So then we have your superficial exudate zone, all right. We have your superficial exudate zone. Yeah, now this superficial exudate zone shows your coagulative necrosis. Yes, all right. Then comes your granulation tissue, all right, the granulation tissue zone. Yeah, and then you have your zone of cicatrization, which is a thin fibrotic scar, all right. So the histological features for your chronic PUD have 4 histological zones, all right, which we just read. The first being your necrotic zone, yes, which is located in the floor of the ulcer. Second is your superficial exudate zone, all right, which is an example of your coagulative necrosis. Thirdly, we have your granulation tissue zone, all right. Now this has no specific inflammatory infiltrations, all right. Now the last one is your zone of cicatrization, all right, which is a thin fibrotic scar. All right, so lastly, what are the investigations? All right, what investigations do we do for your PUD? The first one is here, we will check the individual's hemoglobin, all right. The hemoglobin is usually decreased, yeah, due to chronic blood loss, all right. Second, we can do your barium meal x-ray. All right. Third, we can test the patient for your H. pylori. All right. And fourth, lastly, that's your gastric function test. All right. So that was it for today's video. I hope you guys enjoyed it. Thank you and keep watching.